Mary, are you able to see the PowerPoint? I just want to make sure it's been shared.
Yep, I can see
Okay.
it.
All right. So it seems like you might be the only attendee. The good news is that it's a pretty short lecture. So it's a fairly short lecture, so I will not keep you on here for a while. So right now we are, as we all know, we are on week 9, so very close to the end of the session, summer 2 session. But as of probably a few hours ago, you've all received feedback on the topic for assignment 4. I'm looking forward to reading your final paper. I think there are very great, interesting, novel approaches to looking at various social determinants of health and the interplay among some of these factors and how they relate to health and mental health. As you do your research for this paper, do refer first to the description of the assignment as well as the rubric. And if you have any question as you write, let me know. I am only an email away. And again, as I mentioned, you're pretty much near the end of the semester. Today is week 9, and by tomorrow you'll be in week 10. All right, so today we are covering access to healthcare, and your readings of focus for this week, for not week rather, for this module focuses on this topic. Over the course of various modules, we've looked at various social determinants of health. For example, the social determinants how education and income, the interplay between those two factors, rather, or the reciprocal relationship between these two factors, and how they impact other secondary determinants, if you will, that are associated with health. So how your income, your education, of course, determines associated with your income level, and vice versa, and how these two factors really trickle down into, you know, access to healthcare, your place of residence, your neighborhood, and other factors that are shown to impact health and health outcome. So we are focusing on access to healthcare. And by now you've seen that you have read and heard through the lectures that there are numerous other uh, factors that associated for health outcome other than clinical care. But nevertheless, even the clinical care accounts for significantly less variance in terms of health outcome in comparison to various social determinants of health. However, access to care matters because access to care can actually prevent some disease conditions if care is if people seek and engage in care consistently. Also, it could lead to better management when you have access to care. So overall, as part of your readings, it's just an overview how access to care is done predominantly on average. Most people are not paying out of pocket for their medical care or mental health care. Typically you have insurance, and you may have to pay a copay based on the insurance and the type of coverage that you have. So overall, medical insurance is obtained in different ways, including, employer supported, where your employer put a certain amount forward, and then uh, you pay the rest as gets deducted through your paycheck. If you're a Stony Brook, I think it's every 2 weeks or every month. Not quite sure of that. Direct purchase, you can purchase your own insurance. And Medicare, as Medicare and Medicaid has been pretty hot topics in the media lately. I guess more so over the past year, given changes of government. So overall, Medicare health insurance for adults 65 and older, or if under 65, I do not know why my computer, this thing changes slides. I think there's a new um, changes into I believe Zoom that does that, but however, it's not being directed by me. And I don't think it's anything nefarious or supernatural. It's just a weird glitch in technology. Anyway, Medicaid is another way, and it's federally and state funded, and it supports low-income individuals. So access to healthcare, just an overview that, most recent reports show 1 in 10 Americans do not have healthcare. 2010 rather report showed the number of African Americans who were not insured was greater than that of their white counterparts. A 2020 report showed 18% of Latino population did not have insurance. And then a report looking at insurance coverage among GLBT plus individuals shows that this is about 13% did not have medical coverage. And this is pretty consistent in terms of the medical coverage, the percentage of LGBT plus individuals who do not have medical coverage is pretty consistent from a report in 2009. So we see, that hasn't changed, and that's a substantial number. All right, access to care. When we look at a 22 report, that number significantly decreased among African Americans, the number of folks who were not insured in comparison to white Americans. In Appalachian population, because we know geography and absolutely play a factor in terms of insurance coverages that you have access to. So 35% of Kentuckians in 2013, uninsured in 2014 was 11%. So it gives you, the goal is for this is to, in addition to your readings, is to give you an overview of the patterns of insured or uninsured individuals across certain groups, and to think about, okay, what are some things that are really driving access to care? Some of these things may not be new, but it's a reminder of the number of uninsured individuals across certain population is really substantial relative to the population. So it's not surprising that people who do not have insurance are less likely to engage in preventative care. Like, okay, you're completing your annual exam, physical annual exam, or doing anything, mammography exam, if you have reached a certain age and have some risk factors, family risk factors for breast cancer. So it is absolutely not surprising. Early detection matters, of course, because it decreases the likelihood of your symptomology or increasing to something else. So your risk might be, you may have for a certain disease condition, if addressed early, may decrease the likelihood of you developing that condition. You might be borderline for a certain condition like hypertension or type 2 diabetes, but with early intervention that may include pharmacology as well as behavioral changes, you can, there's substantial literature to show that you can actually decrease the risk or remove it altogether where you're no longer borderline for these conditions. So even after you have folks who have developed chronic conditions such as type 2 diabetes or hypertension, effective management is really important. So continuous access to healthcare is absolutely important because certain conditions, if not managed, can lead to a secondary illness. Type 2 diabetes, not properly managed, can be associated with blindness. Can be also is associated with amputation of a limb. So there are other, management is absolutely important as well as prevention. But as we know, a lot of money is not allocated to prevention, rather it's management, especially in our country. So the Patient Protection and Affordable Care Act was one of the ways, and you might have heard of it as people trying to call it. I mean, not people have tried to call it. They have called it Obamacare. It really was a significant outcome in terms of addressing the lack of access to care among certain populations, especially populations who are very vulnerable. For example, Appalachian population have increased really high rates of chronic diseases that can be prevented by early access to care. But however, a lot of insurance folks were being denied coverage because of pre-existing conditions. So this is one of the many, many achievements of the Affordable Care Act is increasing access to patients with pre-existing conditions, increasing ability to actually get Medicaid. So during that about 20 million under the Americans rather were not insured under the Affordable Care Act became insured. That is substantial. It's a substantial number, and to see that before that time about 20 million Americans were uninsured. Between 2010 and 2022, African Americans with health insurance and also increased by 3.3 million. And we saw within the second term of the current president, a lot of these things are trying to be undone. There is a consistent attack on the Affordable Care Act, and the goal of this course is not to take a political stance, because that's not the point. We're talking about determinants of health and access to care, but more so how these decisions affect access to care, and how this trickle down to engagement, prevention, and management of care among certain population. So the one big beautiful bill in 2025, it seeks to make a lot of changes. It doesn't only include cuts to healthcare or changing the eligibility requirements to healthcare. The other tax exemption tax cuts that are part of this bill is a pretty the documents is available online if you ever want to peruse it. But basically, it's making coverage a lot tougher for individuals. And some of the requirements are pretty vague. For example, for Medicaid, it's proof of work for able-bodied individuals. I don't understand what, and it's not just me, a lot of other folks within public health, it's not clear what able-bodied means. Is it something that you have to it's visibly, clear that you're unable to work because you may be missing a limb, but there are other illnesses, there are other disorders, they're not, quite apparent, that have shown to affect functioning. Higher copays for patients, frequent eligibility reviews. So the issue with frequent eligibility reviews is that you have a backlog of how folks are reviewed for these type of coverages. And now with frequent, and we don't know if it's frequent, it's annually, at time is not quite sure, then you're gonna have, folks who might go or might have a gap in their coverage as they go to the renewal process. And of course, immigrants not having access to care and changes in patient protection. So, less changes for patients. And also part of this act as it relates to medical care funding is limit insurance option for working class families. Based on economists are estimating based on this act, the disparity gap is going to widen significantly, with 1.8 million individuals might actually be uninsured by 2034. That is substantial. Whether or not you are a student of MHA program, MPH program, that's absolutely frightening. Because to see the number of folks that may become uninsured and how that will relate, how that will impact quality of life. Because if you're uninsured, there are certain illnesses that will go untreated, therefore increasing symptomology and decreasing quality of life, and potentially decreasing lifetime, the number of time the term that you're alive. Although there are many lawsuits in terms of states that are demanding more clarity, states that are demanding that certain things cannot be implemented because they're very vague, or they will significantly impact their residents. So the consistent, I think, scare or the consistent anxiety around providers, whatever providers you may be, is that how you going to manage folks who are uninsured? Because if you have a patient and you're providing care, and then all of a sudden there's a gap in insurance, how do you address that? So it's pretty concerning about the potential impact of this act on Americans' lives, and potentially loss of lives, reducing, life, how long you live. That's substantial. It's a substantial impact that may actually we might see the outcome in terms of health and health outcome and premature mortality increase significantly, by losing coverage for, such a significant number of people losing coverage. All right. Some of the, I mentioned earlier, preventative care is absolutely the way to go. Of course, you want to prevent a condition, a likelihood that somebody will develop a condition based on certain risks that they're presenting with. However, we know that's not the case. There's less money allocated for prevention because it's not reimbursed. Prevention for any type of disease condition is not typically, reimbursed in healthcare. So the incentive for doing preventative programs, certainly in certain population, is very it's very low, especially within the healthcare field. However, there's been a lot of public health intervention research trying to increase preventative care among African American and Latina women, for example, follow-up testing for abnormal cervical screening, because we want to make sure, because that's a risk factor for certain cancers. And among Asian women, some work has been done among Asian women to increase receiving mammogram, because we see there's for Asian women, there's research for Asian women 40 and over, they're less likely to receive a mammogram in the last 2 years. So there's been substantial effort to increase prevention, engagement in preventive care, and within public health. Not at all am I saying within healthcare system there has not, but because of substantial changes and because historically not a lot of money is spent on prevention. A lot of this work tend to be within public health, the public health sphere. Moreover, Black men are less likely to also engage in preventive care. And we also see that because of that, there's increased risk of certain conditions that can be managed with early prevention, as I managed type 2 diabetes, hypertension, certain cancers with prevention and engaging in annual care. That tend to be low among Black men, including as well as Appalachian population. So, as I mentioned earlier in few slides earlier, that there is an increase in care across population, especially with the Affordable Care Act. However, engagement in care also remains significantly low. Currently, it remains significantly low. However, we know over the past year there's been substantial increase in folks who are uninsured, rather, because of the beautiful bill, including African Americans. Again, my apologies for this slides dancing all over the place. So what are some internal factors? So within the healthcare system, what are some factors that might be driving care? So we talk about, other factors such as, health, rather education, income, the interplay between those factors, where you live, how you have access to care, and also that matters, and we'll talk more about it. But within the healthcare care system, rather, there are other factors that might be have shown to be associated with lack of engagement in care among certain populations. So availability of primary care providers. So even within Stony Brook, it is very hard for folks to get a primary care appointment because the ratio of primary care providers is pretty low. And unfortunately, it's not the greatest in comparison to other places. The incentive for salary is not really comparable to other places in the city. Available specialty care is also an issue to preventative care as well as management care. So some of these things that we have seen continuously also impact care is, the conflict between when, services are available, hours of operation and the patient's work schedule. So the typical 9 to 5 or even 9 to 7, if you're getting a fork at 6:30 or at 6 o'clock and you have children, or it will make it hard for you to have an appointment. So the conflict between hours of operation, there's been a lot of efforts to trying to extend hours beyond the 9 to 5, or have certain have certain hours during the weekends, although the weekend schedule tend to be pretty short, 9 to 3 or 9 to 1. But nevertheless, there's been some effort in addressing that problem. But it's a problem that continues to be a strong factor associated with lack of access to care in terms of consistent engagement in care and access to quality care. And that's really important because you may have a primary care doctor. Are you receiving quality care? Do you feel like, your complaints are being addressed, or are they being addressed? They're not being addressed because the person is not properly trained based on your presenting symptoms. So also lack of respect in the provider-patient interaction. These are some of the factors. It's one of the other factors that, among other factors, one of the substantial factors that really show high correlation between not only seeking care but also accessing care consistently. because of the barrier to this. So here are some of, in primary care availability. In Appalachia, 66% primary care physicians per 100,000 population. That is substantially unbalanced. Problem because unbalanced numbers because there's no way that low of number of primary care physicians can even extending their hours to make sure that they're seeing these patients and in a consistent basis because it's just not doable. So when you have such an unbalanced ratio, you're going to have problematic prevention engagement in any type of care. So specialty providers, that is one of the critical issues, as I mentioned. In some areas, patients, some folks have to travel very long distance to meet with a provider. But what if you do not have a car? What if you do not have the money to pay for gas because gas is costing an arm and a leg these days. So these are things that some of us may not think about, but however, might be driving the low engagement or inconsistent engagement in care that you're seeing in the population, the patient population you are serving. So thinking about these things, how that's really important. And also, if you don't, you're less likely to engage in care if you see, okay, the provider may not be ideal based on your presenting symptoms, based on their explanation or lack of explanation, and their approach to treating what is going on. And some providers do not accept, certain medical insurances. I have a patient I have been trying to connect with trauma type of work. And unfortunately, this person who has, I forgot what type of insurance that she has, but most providers do not accept it because they feel like it's just, the paperwork that is needed to get reimbursed, it's quite substantial and nobody really had that much time for it. So it becomes a barrier when there is a provider. However, your insurance, they do not take your insurance. So we talked about conflict of between hours of operation and work schedule. Also, it's just when folks work several jobs, they may not able to attend appointments. Often, some of the research for providers in assessing their view of certain population and not engaging in care consistently, some of it may feel like some of it it's kind of around attitude with care. For example, folks who may feel like certain population or really do not take their care seriously. So they don't take their treatment seriously. So they're less likely to keep appointments or cancel, have higher rates of no-show, which may to them seems, lack of, a poor attitude toward their care, where in reality, people have real life obstacles that may be preventing them from attending the appointment, from especially when you have comorbidity where there's we have to see multiple different doctors for different issues. It may become burdensome and you're working several jobs, for example. Any question, Maris? Okay, if you have any questions, you can let me know, comment.
No.
All right. I think there's another person who just joined us. Irene, welcome, Irene. Access to quality care. In certain, I'm not sure if you've seen this term, patient-centered care. You probably have heard this term before you took, you took this course, but it is essential. A lot of people use the term, however, it's not demonstrated in the day-to-day interaction between patient and providers. It's really one of the obstacles to consistent engagement in care is because some patients, and this is substantiated by the literature, some patients feel like their health needs are not really being met because a treatment protocol is giving to them. Rather, it's an outcome of a collaborative effort between the patient and the provider. In my work in obesity, and when I was at Brown University, and we had a center for it's a weight out of the that center was a weight loss program. It's a pretty multi-level type of intervention where not only you meet with a psychiatrist, with a psychologist, nutrition, you know, have regular checkup with your other specialty doctors based on certain conditions that you have. We saw that for a certain subgroup, they were not losing weight. They also were not adhering, for example, to the protocol for their dietary plan. At first, they meet with the nutritionist, for example, and they come up with there's a plan after by the end of the session, but nevertheless that we saw very low adherence to this. And of course, naturally, the nutritionist was a little bit uh, annoyed because all this lack of effort, and every time you see this patient and there's no changes. And one of the things that we saw as clinicians, but also as clinical psychologists and researchers, is more so a protocol may look, or treatment plan may look great, and it's substantiated in the literature and shown to be effective. But nevertheless, it's always good to ask the patients, what are some obstacles? What are something you may think that may hinder you from engaging in this treatment protocol? And first of all, the treatment protocol, as I mentioned, having been developed collaboratively with the patient, increases the likelihood of engaging in them, in that protocol and adhering to it long term. But even with that, I always follow up by saying, yes, we've come up with some, clear plan here, but what are some obstacles that may get in the way of you implementing, this plan? And that really help you to work around and partner up with the patient to really develop some strategies of potentially emerging barriers. What are some things that may emerge as you're trying to do this? And what is a practical plan that you can engage in that decreases the likelihood of, increases the likelihood of you overcoming this barrier and adhering to this plan? So when we actually tailor this approach, we see a lot of increase in terms of dietary pattern, adherence to dietary plan. Of course, that trickle down to weight loss, because it helps you really to further tailor your treatment protocol or to the patient by partnering with them and getting their insight into barriers as well as facilitators to change. So I mentioned showing respect. Partnering with a patient and working collaboratively with them is one way to show, it's a substantial way and a very important way to show respect. And a lot of qualitative research, even though, I'm trained as a quantitative researcher, but at first, but I have spent a lot of time understanding qualitative research and therefore being trained as a qualitative researcher as well, because I think qualitative information gives us potentially can give you insight that may not be captured in a quantitative survey as it relates to healthcare access. There's some, quotes, examples of why some patients in this study felt like, for their inconsistent engagement in care or barriers to care. So One is like my daughter who has Medicaid for her and her children. However, she had multiple experiences with providers who really show a lack of respect and very judgmental and rude. And one based on one occasion, the daughter was in tears because she felt like because she was on assistance, because she was getting that she has this type of insurance, she was viewed as not having lack of insight into what's going on and being treated like an idiot, as she mentioned. So there's really it's bias. So is there other biases that we come in with, whether or not whether you're the medical provider, whether whatever part you're playing in healthcare as you interact with a patient, are there some biases that really may impede that interaction with the patient that may trickle down to why they're not showing up for a certain program, they're not showing up for their appointments? So what about the provider interaction? People should be respected, and we see perceived lack of respect is a barrier to care. Another one is like my former doctor looked at me in a gown at a table and nurse stated she's a welfare trash and went on to criticize. And these are pretty extreme examples of, some of the, patient, provider patient barriers. Some of them can be pretty subtle rather than outwardly, criticizing a patient based on their, the type of insurance, based on their SES. Another one, this has to do with a gay male, went to get tested for STDs, and the implication the whole time was that for one of the provider was going that it was going to come back positive. It's very likely that you have an STD, the provider says, based on what you are telling us. And the patient basically said, I didn't tell you anything except for the fact I am gay and I was sexually assaulted and I'm also sexually active. So in this case, this is a person who was presenting because they were sexually assaulted, checking for STDs. But however, because of their sexual orientation, the assumption is that, your lifestyle is associated with increased likelihood of having STDs. So the judgmental aspect is really problematic. And within public health, within MHA healthcare system, lack of having respect for folks who might be different than you, because the barrier is not asking you to co-sign, as one of my colleagues said, what the people's orientation. They're not asking you for your approval, rather you are there to provide care, and you absolutely need to check and assess whether there's some biases that you have that really impact the interaction with the patient, because you may have access to health insurance, you may have access to providers. However, the treatment is one of the barriers to care. So overall, what we talked about is, healthcare coverage is really essential, even though we talked about so many in previous modules, so many other social determinants of health, including income, education, that really trickle down to access. And we talk about different ways in which insurance coverage is obtained, the impact of the recent changes of the big beautiful bill, that how it may exacerbate existing disparities in health coverage, and the potential impact on health and health outcome, and reduce life expectancy among certain population that already have decreased lower life expectancy than other groups. And we talk about also central barriers within the healthcare system that I believe that changes can be not easily implemented, but it's much more doable than having changes be made at the federal level to a certain extent. There, I think quality of care, defining it more clearly, assessment of provider and patient interaction, having patients not only the satisfaction survey, we don't know where they go. We don't know whether or not it's used to improve patients' interaction with patient. So more transparency in terms of how these measures are used to improve care is really important. And also, access to quality care. It's really essential. If you may have access to a provider, however, the provider is not competent in the type of treatment that you are seeking. So these are some of these substantial barriers. So here are some references if you find that you want to do more reading on this topic. All right, I am gonna stop here. Do you guys have any questions?
I don't think so.
All right.
Yeah, I feel like I've been doing so much access to care just because that's what my paper's about. So,
Okay, well, great. I am looking forward to reading your paper. So as I said earlier at the beginning, as you write your paper, if you have any questions, please email me and I will bid you good night so you can have the rest of your evening.
sounds good. Have a good evening.
You too. Bye-bye.
Bye.
Bye, Irene.
Thank you. Bye.